book, which Elora has written with Robert Preston, and it's called Death by Appointment, A Rational Guide to the Assisted Dying Debate. And if you're a parliamentarian, an MP or a peer, you will have been sent a copy of this in the post. It should be somewhere in your office. Please do let us know if you haven't got it and would like another copy. It analyzes the complex and emotive subject of assisted dying and breaks it down into its component parts of the law, medicine, society, the overseas experience, public safety, and it presents a clear analysis of the evidence on this subject. And its authors make clear that they are not convinced by the case put forward for legal change, but they respect others who take a different view, and it's a very balanced and sensible account of the case, why we shouldn't be changing the law. The second thing to say is quickly why we've set up the APPG. And our view is, and we have a large number of parliamentarians of all parties who've joined us. We think we need to have this debate should be in the context of a much wider discussion about the end of life. Most practically, we need to radically improve access to palliative care. That's our fundamental belief. And we think that changing the law to allow assisted suicide would have profound consequences for all of society. So that is our twin mission, to stand against the campaign for assisted suicide, but also to campaign for excellent palliative care for all. And it's perhaps relevant that it's Dying Matters Awareness Week this week. So a lot of people around the country are thinking about what it means to die well and to die with the right support and the right care. And we want to be part of that debate. The other thing that's relevant, of course, is it's a new session of Parliament this week, and with the opportunity for new legislation to come in. And I'm very aware that many people on the other side of this debate will be hoping to find an opportunity to bring forward legislation to change the law. So we're keen to influence my colleagues in Parliament to think again. We want to sound a note of caution on this topic. Now, please do put your questions into the Q&A function, and we're going to hear around 10 minutes each from each of our speakers, and then there'll be time for questions. So please put questions in, and I hope we can come to as many of those as possible. So I'm now going to turn to Catherine Sleeman. She holds a chair in palliative care at King's College London, and she's an honorary consultant in palliative medicine at King's College Hospital NHS Trust. And her current research includes palliative and end-of-life care in care homes during COVID-19. She's the academic lead for the Marie Curie Better End-of-Life Programme that aims to understand what it is like to die in the UK and how to improve this. So, Catherine, thank you very much indeed for joining us. And I'm going to hand over to you now. Thank you.
Thank you so much. So thank you for the invitation and that nice introduction. So as you've heard, I'm a clinician in palliative medicine and also an academic based at King's. And I thought it would be helpful to start by summarising my overall position. I am not someone who considers assisted suicide or assisted dying to be intrinsically or kind of morally wrong. That is not my position. My position from clinical experience, as well as looking at the academic evidence, is that assisted dying shouldn't be legalised because, in my view, the risk of harm of changing the law outweighs the risk of harm of leaving it where it is. And over the next few minutes, I want to consider four main issues. The first of those is autonomy. So autonomy forms the basis of almost every argument in favour of assisted dying. You'll hear it's my right, it's my choice, it's my decision. And framed as a rights-based issue, particularly from the mouths of people who are themselves terminally ill, it is very hard not to be moved. Who am I to deny someone their right or their choice? But I'm also sure, because I look after them in my clinical practice, that there are people at risk of being harmed by a change in the law. And there's an intrinsic imbalance in this debate, because on the one hand, proponents of assisted dying are generally informed, educated, quite autonomous people. The ones we see, the ones in the public eye, generally have a platform to express their views from. Whereas the people who might be harmed by a change in the law are by definition without a voice. They are not capable of telling us about their vulnerability or their experiences of coercion. So we have to build our structures and legislation around the weakest, not the strongest. So that brings me to my second point, which is safeguards. How do we then protect the vulnerable within assisted dying legislation? With appropriate safeguards is the standard response. But which safeguards are appropriate? In fact, how safe is safe enough? Let's put it this way, what margin of error would we find acceptable? I am far from convinced that we have even explored these issues adequately, let alone found any answers to them. Mental capacity is probably the most important safeguard, but again, how much capacity is enough capacity for this decision? We know from Oregon that the individual values of the doctors making the capacity assessments are likely to affect those outcomes. So I'm likely to have a different threshold for assessing capacity for assisted dying than the next doctor. Do we understand enough about that safeguard? And what about the 6-month rule? I have several concerns with this. First, as a doctor, I know that it is impossible to determine prognosis with any degree of accuracy. I have had many patients who we thought were dying several times before they actually did. Second, the 6-month rule is arbitrary. It makes no sense from a clinical perspective. Why 6? Why not 4? Why not 10? There is nothing special about 6 months when it comes to terminal illness. But third, and I think most importantly, the 6-month rule is discriminatory because it excludes those people who arguably have the greatest need for an assisted death because their life expectancy may extend to years. Why should discrimination against people with slower progressing conditions be tolerated? Oregon, where the Death with Dignity Act has been used since the late 90s, is frequently held up to us as an example where there is no evidence of abuse of the law to reassure us. But in my view, Oregon simply doesn't collect the sort of data necessary to determine this. Data on assisted deaths in Oregon comes from a form filled out by the physician who wrote the lethal prescription. Are we really willing to base our laws on that level of evidence? So the third issue I want to address is it concerns society. We know that societal values and expectations change according to the laws we make. So what sort of changes might happen if we legalize assisted dying? For people with a terminal illness, what extra pressure would a change in the law put on them? Is there not a major risk that legalization would change the behavior of people who otherwise would never have considered it? And a critical issue is that we're not just talking here about the small number of people who otherwise might choose to go to Dignitas. We are talking about a seismic change for all of society. Yes, a 6-month rule might make legislation more palatable for us, but once that's done, it will be a small step to increase it to 12 months, to any condition, to anyone. This is what we've seen happen in almost every other nation that has legalized assisted dying. So if there is professional or public discomfort with the prospect of assisted dying for people with longer life expectancies, then we have to explore this. We have to understand it, not sweep it under the carpet while citing an 80% public support statistic. So my fourth and final point concerns dying with dignity. We all agree that dying should be dignified, but dying frequently, sadly, is not. We know that society is aging. The number of people over 65 is going to quadruple by 2050. We are dying slower, more complex, and in many cases over medicalized deaths. The late Baroness Mary Warnock, who I'm sure you know was very pro-assisted dying, wrote, "Doctors appear to be hardwired not to mention death." I think there's a truth there, and this may well lead to people being overtreated near the end of life. But the solution to that problem is medical education. It's not assisted dying. People frequently cite feeling a burden as a reason for wanting assisted dying. Isn't it our duty to find ways to enable these people to live without feeling that they are a burden? We know that a palliative care approach could benefit far more people than currently receive it. It's wrong and it's irresponsible and it's dangerous to frame this as a choice between suffering or suicide. In England, the amount of dignity you can expect in dying appears to depend to a large extent on where you die, with people who die in hospices experiencing on average the most dignity, and people who die in hospitals experiencing on average the least. Numerous reports over the past years have highlighted profoundly inadequate and variable palliative and end-of-life care services. Our data has shown that just 4% of health and wellbeing boards in England, so 6 out of 152, actually have a priority around palliative and end-of-life care for their local populations. And yet we know that there are huge inequalities in access to palliative care by age, by diagnosis, by ethnicity, by socioeconomic position, by rurality, by geographical location. And in many cases, these inequalities not only persist, but they're getting bigger over time. We also know, because we've looked at the data, that palliative care needs in England and Wales are projected to increase by about 25% over the next 20 years. So that means that by 2040, there will be an extra 100,000 people dying in our society who will require care. That care will come from hospices, and it will come from specialist palliative care teams, as well as district nurses and GPs and generalists. What are we doing to ensure that everyone who needs palliative care receives it? I'm very worried that we're not doing enough, and let me give you a couple of examples. In 2004, there was a NICE guidance that recommended that every acute hospital should have access to 7-day face-to-face palliative care services. An audit done a decade and a half later showed that just 1 in 3 hospitals had actually achieved that. And we know that around 70% of hospice care is funded by, well, what is essentially fun runs and second-hand clothing. And we also know from very recent experience that COVID has exposed the extreme vulnerability of the hospice sector, as services found themselves unable to provide direct frontline care due to shortages of essential medicines and equipment and staff. And I guess the point I'm trying to make is that we as a society, we should be angry about this. We should be outraged. But I think we should be channeling that outrage and our efforts and support towards improving care for the ordinary 500,000 people who die every year in this country, and not towards the wishes of a vocal minority. Thank you.
Kathleen, thank you so much. The very, very powerful and useful professional insight there. I very much appreciate it. So I'm now going to come to Kathleen and Elora. Kathleen joined us from Ireland, and Elora Finlay, our good friend, is going to take over from here and ask Kathleen some questions. So Elora, over to you.
Fine, thank you very much. And we really are most grateful to Kathleen Rogers, who's our next speaker. She's been a prominent voice in the media. She's thought about this issue in detail, and she's contributed. She has motor neurone disease herself. And when she knew there were potential plans to introduce a so-called Dying with Dignity bill, she wrote to the Irish Times about it. And in that letter in March, she wrote, and I quote, if I may, Kathleen, quote you, "Having a choice to opt in or out of assisted suicide may seem straightforward, but it isn't. Living with a terminal illness is hard enough. Having to also deal with the message this bill is sending me, basically that my life is not worth that of other people who are encouraged to live no matter how great their difficulties are, is making my terminal illness even harder to cope with." So thank you, Kathleen, and the letter was longer, people can read it online, and you very generously said you'd answer a few questions. And so if I might start off and ask you, when you were diagnosed with motor neurone disease, such legislation would have appeared to encompass you as an eligible person for lethal drugs to end your life. As it happens, you were diagnosed more than 6 months ago, but that's easy to say with hindsight. So can I just ask you how proposals for an assisted dying law make you feel as somebody with motor neurone disease?
Okay, well, right. I think my first reaction is just that I feel segregated from the majority of people who are being told, no matter how great your difficulty is, no matter how your situation in life is, please don't commit suicide. We want you to live and we will help you to live. Now, what's being offered to me is help to die. So that would be my immediate reaction to all of this. And why should I be in that category of people who I think the message is we've given up on you. You know, if you want to die, that's okay. We'll even help you do it. Whereas everybody else, the message is, oh, we don't give up on you. We think of that your life is of value, and we want to help you to live it, no matter what your problems are, and help you to resolve them. Yes, I suppose that's it really.
Thank you. Kathleen, I know that you'd previously been a carer, and now you've had to switch, if you like, to the other side from being a carer to being cared for. In that process, have you seen people make any value judgments over your life?
I can't say I have over my life, because I suppose I'm surrounded by people who know me well and who love me well and see me first and my motor neuron disease second. But I do know that there's a lot of dangerous assumptions out there in the general public. Like I've heard it more than once. People would say about, people who need their their care needs met by others, that they have a poor quality of life or no quality of life. Now, these people are talking about my mother, who has advanced dementia and needs to have everything done for her. And it's, you know, it's an insult really to my mother that these people presume she has no quality of life or poor quality of life. They don't even know her. She can have a very rich inner life. And for me, I'm heading in the same direction. I'm going to be needing all my care needs met by other people down the road. Already, I need some of them met now. But that doesn't diminish my quality of life, not at all. And I think that these are the dangerous assumptions that people make about other people. And it's hurtful and it's inaccurate. And I think it can lead to even people supporting this kind of legislation, because they just make these assumptions and judgments that your life is not going to be worth living if you need other people to do stuff for you that you can't do for yourself. And that's so untrue.
Kathleen, you've previously said, and if I again can quote you, choices don't exist in a vacuum. Can you explain a bit about what you mean by that?
Well, in particular, on this issue, it's like it's often been said, okay, you don't have to avail of assisted suicide if it's available, but why stop other people doing it? But it's very naive to believe that if this legislation comes through and one person avails of assisted suicide, that they are not affecting a whole group of other people. For instance, the doctors, it's called assisted suicide or assisted dying, which means the doctors, the medical profession has to be dragged into it for start off. People who are trained to care for us and cure us or help us to deal with symptoms if they can't cure us, all of a sudden they're going to be involved in that. And then there's the people who are healthy but are suicidal. You know, if this legislation comes through, they're going to see that it's lawful for some people to commit suicide. And surely that's going to impact on the way they're thinking as well. Society says somebody can commit suicide if they're enduring unbearable suffering. So why can't I? There's me. It impacts on me. As I've said, the very notion that the expectation is on me that I can't get through what I'm getting through without the help of assisted suicide, or at least the choice of that. But even more than me, because I'm quite determined to continue my life to the natural end, regardless of any law that comes in. But not everybody's in that situation. A lot of people are maybe in between, they can't decide what the right thing to do is. And they hear like advocates of this law maybe saying they're doing it to save their family, having to see them suffer at the end, or save their family having to care for them. And this can play on the mind of people who have serious illnesses, and they might think, maybe it's the right thing to do to save my family. You know, maybe I'd be considered very selfish if I don't go down this road. So it's impacting on them, and it's impacting on society generally, because attitudes would definitely change. They're already there at the moment, but they would change for this.
When we spoke before, you spoke about having good days and bad days.
Yeah.
And do you think your attitude might be different on a bad day to on a good day?
Towards this issue?
Yeah.
Oh yeah. Yes, I think on my bad days, to be honest, I can understand why people want this option. I can understand it, because it can be very, very tough. So if the option was available, I think it could be very, very tempting for somebody to go down this road without realizing maybe that, you know, the bad days don't last forever. You have good days after the bad days. So to make a decision based on your bad days is not good. But to have the option there in the first place, it's kind of like a burden of choice on you, whether to make it or not make it. And as I said, there's so many factors that come into it. And you can't make a decision that's so huge when you're feeling so low and you're dragged down so low. And a terminal illness will do that to you anyway. It's something
Kathleen, Kathleen, thank you. You've been incredibly open and honest with us, and you've shared your own feelings, which is a really generous thing to do. And thank you so much. And also, can we wish you well, because we know you're caring for your mum, and that your mum actually is pretty ill in these last couple of days too. You did make a video, which is really helpful. And we're glad to have you here. And also, if that's okay with you, to share your video, which I think you said to me you felt was your take-home message for parliamentarians. Is that right?
Yeah, I think so. And just one other take-home message. Please know that if this becomes law, it's going to be almost impossible to reverse it. So it's a huge, huge step to take.
Thank you. And I wonder if we can just go to show Kathleen's video now. Thank you. Thank you, Kathleen.
You're welcome.
Hi, my name is Kathleen Rogers, and I have motor neuron disease. This puts me, of course, in the category of terminally ill people, someone the Dying with Dignity Bill is designed for. But I don't want it. I object to the name, first of all, as it suggests that shortening our life is the only way for a terminally ill person to die with dignity. This is not true. I intend to live out my life to its natural end. This end will be difficult, I'm under no illusion, but I have faith that the support, care and respect I currently receive from the health professionals, the palliative care team from the hospice, and from my family and friends will continue for as long as I need it. I will live out my life to its natural end, and then I will die with dignity. You may say, fair enough, but why deny others this right? The truth is that such a decision to avail of assisted suicide cannot be taken in isolation. There will be knock-on consequences for all of society. Our medical profession, those trained to preserve life, will be turned on its head. Regarding the law, with this bill, the state will be sanctioning the death of a certain section of the population. What message would that give me and those like me, especially those struggling with feelings of being a burden on others? I think the message would be, your lives don't matter as much as others. We will not waste time trying to encourage you to seek a better option. Go ahead and end your life if you want. So, I would ask our politicians not to vote for any bill which seeks to introduce assisted suicide or euthanasia. In the meantime, speak to people like me, those in the medical profession, and those involved in hospice care. We can tell the story from another perspective, one that needs to be heard.
Thank you, Laura. And Kathleen, thank you so much indeed for sharing that with us. And it's a most wonderful film as well. So we really appreciate your time with us today and everything that you've said. Thank you. Right, so our last speaker is Carol, who we're going to come to now before questions. She's qualified in 1983, has been actively involved in patient care all these years, palliative medicine consultant based at Southampton General Hospital, mainly working in the acute hospital setting, but also working clinically and in a teaching capacity in hospices and the community. So Carol, over to you. Look forward very much to hearing from you. Thank you. You need to unmute.
Sorry. Thank you, Danny, and thank you for inviting me to this launch meeting. Kathleen, that was amazing, and I feel it's going to be quite hard to follow, but hey. It feels really auspicious that it's Dying Matters Week this week. It's also today International Nurses Day. I work alongside lots and lots of fantastic nurses and always have done, and I'm often mistaken for a nurse and proud to be so. In this last presentation, I'm going to present a few key points illustrated by anonymized cases from my clinical practice, and I'm going to use some slides with the key points. The examples relate mainly to my work in hospitals, and hopefully, as well as other things, will serve to illustrate the concept of dying-friendly hospitals. There are many more that I and others can relate from a wide range of health and social care settings, especially the community and hospices, and much research to read about dying well. So firstly, normalizing the idea of assisted suicide. It's very important to think about the message that licensing assisted suicide by law sends to people who are probably approaching the end of their life and those who are fearful of when that will happen, as well as to their families and to healthcare professionals involved in their care, just as Kathleen has just talked about. That sends a message. It sends the message that ending your life is an appropriate thing to consider if you are terminally ill. And that changes the dynamic, especially if you're feeling a burden. It changes the dynamic between you and your family and the dynamic between you and your healthcare professionals. That will have consequences. It's very likely, as Kathleen said, to encourage someone to think that they're being a burden to their families and perhaps to health and social care services, and that therefore they should hurry up and take their own life by taking lethal drugs. If that person is already vulnerable or feeling vulnerable for whatever reason, including depression, those thoughts are very likely to be intensified, and that doesn't feel like a good thing to me. I'm very worried, truly worried, about the increasing number of cases of people with mental health issues, depression, schizophrenia, anorexia nervosa, for example, and other vulnerabilities who are dying prematurely by physician-assisted suicide, PAS, or physician-administered euthanasia, PAE, in jurisdictions where these have been legalized. The doctor-patient relationship. Most doctor-patient relationships are built on trust. They have to be. We need to be sure that in treating us or advising us, our doctors will at least not knowingly or deliberately bring us harm. But we need to remember that the doctor-patient relationship is in most cases a very asymmetric one. It's not equal. We'd like it to be, perhaps, but it's not, because doctors nearly always have more medical knowledge than their patients. That's why patients often look to their doctors, not just for treatment, but also for guidance. And that, in turn, is why embedding assisted suicide within medicine is particularly dangerous. A patient may say to a doctor that he or she would like something to end it all. Very often, those requests are not serious. They are more designed to convey feelings of desperation and to seek reassurance or a different treatment regime. They need exploring, not acting on straight away. Yet a doctor who under an assisted dying regime agreed to pursue such a request risks sending the patient the message that in the doctor's professional opinion, the patient's clinical outlook is bleak and ending it all is absolutely the right course of action. Next slide, please. Prognostication. It's a dark art, I'm afraid. Kathleen touched on this slightly. It is very difficult to predict how long people are going to live. It's much easier in the last minute, hours, or few days of life, and much less accurate when prognosis stretches to months. And as you can read, in Oregon, some people prescribed lethal drugs have lived for over 3 years. But also the natural history of diseases is changing. Medicine is changing all the time and progressing. For instance, I've been involved with many patients with cystic fibrosis over the last few years. Sometimes I dip in and out of their care over years. One such patient who knows that I'm telling his story, and that is his choice, was spending 2/3 of his time in hospital because of repeated severe infections. Then the COVID pandemic hit and he was too scared to be readmitted. He thought a better option would be to give up and die. However, he became iller still and eventually asked to be admitted because he felt awful and knew that he was very, very unwell. Lots of clinical teams worked together and with him, and over the odds, over several weeks, he recovered. And what's really important to this chap is that during that time, he became eligible for one of the new disease-modifying drugs for cystic fibrosis. And he was well enough now to start it. And he did. And it worked. And he got better. So he was spending 2/3 of his life in hospital for the previous 2 or 3 years, and he's not been in a hospital for a year. And very importantly, his zest for and enjoyment of life returned really quickly. So medical interventions are evolving all the time and becoming more nuanced and better individualized. Ill people and their families need to be aware of this and ask questions about it, and doubtless Google it. Another story. Treatment was stopped in a patient in their 40s after yet another heart attack. His heart just wasn't able to pump. The next morning, I was asked to see him for symptom control of a dying patient. He looked like he was dying, and he also looked like he was hallucinating. I talked to the family and to the patient, even though I wasn't sure that he or she could hear me, and I treated the hallucinations. I went back a couple of hours later. He looked a lot more settled and still like a dying person. The nurses asked if I could organize a hospice transfer, and I said I thought that would not be the right thing. He wouldn't recognize his environment, although it might be good for his family. It might be a good environment for his family. And I thought he was too ill to put in an ambulance. Early evening, I went back again. The bed was empty. I thought he died. And then I said, oh no, he picked up a little bit, Carol, and we sent him to another ward, a lower intensity ward. So off I trotted to the lower intensity ward and went in to see him. And he said, oh, I recognize your voice, I think. Did you see me earlier? And I said, yeah. And he said, I want to go home. So I explained that he was still extremely ill, even though he was rather better than earlier, that he couldn't go home right now. And with his family, I talked about the uncertainty of the night. Things could go either way, and he completely understood that. He had fluctuating capacity, but I waited for the moments when he had capacity, and we were able to discuss this fully. The cardiologist and I said we'd go back the next day. His family stayed the night. Next morning, better still. So we titrated down the low doses already of symptom control drugs he was on and restarted his medications. A week later, he walked off the ward to go home, merrily waving at everybody and thanking them for saving his life. We get surprises. We get surprises in medicine all the time. Some are nice like that. Some are less nice. I'm afraid COVID has served us up lots of not nice surprises. And I think and hope that our healthcare services have learned a lot from them. Next slide, please. Sorry, bear with me. So I want to talk about allowing a natural death, and my example is from the intensive care unit. So feeling a need to end one's life prematurely is completely different to deciding to stop treatment, completely differently, ethically, morally, and legally, and completely different in experience. A patient of Muslim faith was on the intensive care unit for sophisticated treatments because many of his organs were failing. He had decision-making capacity. He was clearly informed of the situation. There were a number of options. He weighed them up. He talked to his family, and he decided that the following day he would like his disease-prolonging treatment stopped. And that's exactly what happened. And he died. We were unable in this instance to get him home as a rapid discharge home to die. So he died in a side room on the intensive care unit with as many members of his family as he wanted around him, with culturally sensitive music playing in the background that he had chosen, and after the Imam had been to visit him. People already have choice. Those with capacity can ask to stop treatment. Some people, as Kathleen will know well with motor neurone disease, choose to stop interventions like in non-invasive ventilation, help with breathing, or feeding through a tube in the tummy. Not everybody does. That's okay, it's their choice. But people can choose to stop treatment at any time or even not to start it. They need to be co-pilots in their treatment and care. There's a current drive towards realistic medicine and shared decision-making, and those have a real potential to make a big difference. That's about co-piloting. So in conclusion, we can take the slides off now, thank you. I don't think the current law needs changing. There's already a right to die, and we shouldn't confuse that with a right to be killed. The law is here to protect us from harm, including self-harm. A minority of people who are highly resolute may find the existing law not to their liking, but we have to consider the collateral harm that legalizing assisted suicide could bring to much larger numbers of vulnerable people. Thank you.
Well, thank you very much indeed. That's very, very powerful and helpful insight from you. I'm now going to come to questions. We've got about a quarter of an hour, so I've had a batch of questions come in. I'm going to take the ones from parliamentarians first, which I understand is APPG rules. And I think I'm going to start with this one for you, Catherine, but others feel free to jump in on it as well. It's from Miriam Cates MP. Who raises this question about this worry about a slippery slope or a grey area if the law were changed. She says that we have to draw the line somewhere, and surely we should draw it on the other side. Or she wonders whether, shouldn't we draw it on the other side of this small number of people who could be said to really need an assisted death? Why do we draw the line where we do? Catherine, can I come to you for that?
Yeah, sure. Thank you. So yes, first, we all know that wherever the line of the law is drawn, there'll be some people who think it's in the wrong place. We're never going to please everyone. Second, I would say we have to move away from thinking of this as a kind of binary issue. It's legal or not legal. There's nothing in between, because actually assisted dying laws exist along a continuum. And what is also very clear is that they change. They're not static and fixed. And in almost every nation that has legalized assisted dying, we have seen that law change over time. For example, Belgium, which became the first country to authorize euthanasia for children, and Canada, which within months of the medical aid in dying bill, announced the possibility of extending that to what were called mature minors and those with mental illness. So although I find the terminology a bit unhelpful, I think we have to acknowledge that there is a slippery slope. It exists. It's not a question of is there one, but yes, there's one. We've seen it. We've seen it in every other jurisdiction, and we have to go into this with our eyes open. I think we have to go into this with the perspective of accepting that if we legalize assisted dying in this country, within a few years, it is highly likely that the criteria for who is eligible will be extended, and it would be very dangerous and very disingenuous to pretend to ourselves that that is not the case, that that is not going to happen. So yeah, I think that it's not a danger of a slippery slope, it is a slippery slope, and we need, if we're starting on this track, we cannot pretend to ourselves that, oh, we've got some nice safeguards, including a 6-month rule, and everything's very tidy. That is not the case. If we go down this route, then we will find that things stretch and change and perhaps become something that we didn't think we were signed up to in the first place.
Thank you, Catherine. Does anybody else want to jump in on that question, that point? Okay, Catherine, thank you very much indeed. Next question is coming from Andrew Mitchell, who leads the campaign in Parliament for a change in the law. So we're pleased to have him with us today. He makes the point, Laura, I'm going to come to you for this one, if that's okay. He makes the point that in Victoria, Australia, they've changed the law to legalise assisted dying and invested in palliative care. Why can't we do both, is his question.
Well, thank you, Andrew, and it's good to have you with us. First of all countries in the world, to a greater or lesser extent, have invested somewhat in palliative care because they've realised the advantages of it. Some have done it, such as the Netherlands, after changing their law, because they realised what's happened. So what happened in Belgium was similar. There was money on the table for palliative care. It started from a very low base. They really, in these other countries, they haven't had the same specialist training program that we have created here. And it all looks fine for the first year or 2 or 3, but actually the numbers of assisted suicides or euthanasias or both just escalate. And of course, it isn't only putting money into some services. You've got to fill those gaps that Catherine told us about, uneven spread at the moment. At the moment, hospices are mostly funded from the voluntary sector. Now, I would say to Andrew, when you have proper NHS funding, you have got equal access across the whole country, and we know that there aren't delays in referrals, and we've been able to up education of all people looking after patients who may be dying to improve access. Well, then come back and we'll see whether there is still a need and how it's contained. But certainly in Belgium now, which is where exactly that situation happened, we know that the Belgian authorities reckon that they don't even hear about 50% of their euthanasias for the very reason that Catherine Sleeman laid out. It's the doctor themselves who has to go through the hassle of reporting. And it's human nature that firstly, you don't want to undertake more hassle than you need to. And secondly, you don't go and self-report if something hasn't really ticked all the boxes properly. There's no way that you know how the consultations happened or anything. So I really think that thinking that you can put palliative care funding in and then it'll be fine is to miss the point that has been made by everyone this evening, which is that this is a really dangerous road to go down.
Thank you, Laura. I might just jump straight to Carol, actually, on the back of that, because we've also got a question from a colleague, Stephen Crabb, who's asking about the system of palliative care we need. I mean, we all agree, as Andrew's just suggested, that we need a better palliative care system. Carol, without inviting you to try and design an entire healthcare system in a 30-second answer, but just what are the broad outlines of the palliative care system that you think we need in this country?
Gosh, well, I mean, a proper system of palliative care is one where patients and carers and families receive the care and support they need, and it's well coordinated, and it meets those individual needs irrespective of geography, ethnicity, care setting, care provider, diagnosis, and any other circumstance. And where necessary, in some cases, that might be from diagnosis, in others later in a disease trajectory. And it needs to extend through to either when some people recover. And in my 30-year career in palliative medicine, that's a change. In 1992, just about all the patients I saw died, usually within months. I now dip in and out of people's care over years. And that's what we need. We need proactive specialist palliative care services. I'm a purveyor, for want of a better word, of specialist palliative care. That means that I work in a specialist multidisciplinary team whose sole purpose is delivering palliative care. We deal with complexity, and we certainly, particularly in the acute hospital, strive really hard to influence the care of far more people than we see. It depends what you define as palliative care services, because palliative care is also pervaded by many others. It's part of all healthcare professionals' jobs. So GPs will see a handful of patients a year who are dying, community nurses probably more, care home nurses, medicine for older people nurses, emergency department nurses, ITU staff will see yet more. And they all need to be skilled in palliative care, and they all need those skills updating. So part of what this looks like is, and Catherine touched on this, is about education and training and role modeling, and this influence in the care of more people than we see. And we need to think really seriously. There was a letter today in the Telegraph, I don't know whether anybody saw it, from a lady describing, a bereaved woman describing the death of her husband from lung cancer at home. She described it as wonderful. She described the team looking after her, from the GP, the hospice at home service, the hospice, the community nurses, as wonderful. And she asked why this was a completely charitable service with many, many volunteers in it and not run by the NHS. I think this is worthy of at least a meeting on its own, and I should stop there.
I agree. Well, that is indeed, it's in fact the mission of our APPG as a whole. So thank you, Carol, for that. We've got loads and loads of questions. I'm so sorry we're not going to get to all of them. I'm going to come to a question from Carla Lockhart now, and I propose to promote a panelist to answer this question, if we can get her up. Tanny Gray-Thompson, Baroness Gray-Thompson from the Laws, because she's our officer in the APPG and probably the best person to answer this question. So Carla Lockhart is asking, hello Tanny, welcome. Thanks for doing this. That most people with disabilities support a change in the law to legalise assisted suicide, according to proponents of a change. Do you recognise that? And if so, why shouldn't we be listening to them?
It's not something that I particularly recognise, and I think it's one of those questions that if you ask who supports assisted suicide, people will say yes, and then you start talking about the detail and the process and behind it. And I think what we have to be really careful is we have to take it. You can't take it as a decision in isolation of the way that disabled people are treated. And pre-COVID, it was pretty tough. You know, the Equality Act hasn't helped disabled people. You know, we're still fighting for access to goods and services and trains. Trains might be accessible maybe by 2070. So we don't have equal inclusion in society by any stretch of the imagination. And the Paralympics looks lovely, but it hasn't changed the world for disabled people. And since COVID, it's become even harder in terms of disabled people being told to shield, that they don't have any quality of life, they don't have any value of their life. And until some of these things can be addressed, as Laura said, I think it's a real challenge in terms of, because disabled people already will just be encouraged at some point to think, and it's very easy to conflate disability and illness together. So I think there's a huge more, we should be fighting for genuine and true equality for disabled people, not encouraging them to think that they have no value. And for me, I was told relatively recently by somebody, if my life was like yours, I would want to kill myself. Wow. And that for me really brought it home. You know, I don't come at this from a religious standpoint or anything else, but it's like, if you think my life as a Paralympian, as a parliamentary is bad, wow, that and that really worries me, that there's that view that is out there.
Tanny, thank you so much. That's tremendous. Right, only a couple of minutes left. I'm going to ask one more question to Carol and then end with a question to Kathleen, if that's okay. Carol, Andrew Selous, MP, says that he's read that 300 people a year with terminal illness end their life by their own hand. Do you recognise this as a phenomenon? And surely, I mean, what do you say to the suggestion that legalised assisted suicide would prevent those tragedies?
Okay, firstly, I think that figure's hard to interpret. So as I observed earlier, the phrase terminal illness is very inaccurate. What does it mean? So who were these 300 people? What was wrong with them? Where were they at in their treatment? And very importantly, were they depressed? What was the state of their mental health? So we need more context to know what that figure really means. It seems likely that other interventions might have prevented many of those suicides, and we've heard of many of those today. Something we haven't mentioned is advanced care planning. Advanced care planning gives control. Advanced care planning is when people, anybody, you don't need to be ill to do this, anybody can do it, talks about and writes down what they'd want in different circumstances, particularly if they lost capacity or the ability to communicate well. And advanced care planning would, I would reckon, make a big difference to that number. So had any of them been given the opportunity, had it been raised to them that they can have advanced care plans? Just the other day, I've only seen one patient that I'm aware of in the whole of my career has committed suicide. But actually, as it happens, recently we were asked to see somebody who'd been admitted to hospital after an overdose. They'd taken the overdose because they thought it was the only way that they could die. They did not want cardiopulmonary resuscitation. They did not want more chemotherapy. And bizarre though it sounds, but this happens to people who are ill. The healthcare system sort of does it to them sometimes. Bizarre though it's ill, they didn't even realize that they could make an advanced decision to refuse treatment, that they could say no to further chemotherapy, that they could refer themselves to palliative care services or ask to be referred. Our team saw that patient once and they went home. They're now involved with the hospice in the daycare unit and are now wishing to live life as well as they possibly can, just as Kathleen talked about, until such time as they die, and then to die as well as they can naturally and not artificially by other drugs.
Okay. Thank you very much indeed, Carol. Right, well, we are out of time, but I do want to just give the last word to Kathleen, who has been listening. And Kathleen, thank you again for your testimony to us. Do you want to just give a final message to, we've got a large number, we've got over 50 parliamentarians, MPs and peers with us this evening, which is tremendous. Do you want to just give any final message to them as they think about what might come up before us this session?
I suppose just what I said before about if this bill becomes law, we all know that it will just spread and spread and spread and involve more people, and it'll be virtually impossible to reverse. So this is the time to look very, very carefully and to listen carefully, not just people who have serious illnesses who want this law, but to other people like me who don't want laws like this and can see that there is another way, a better way. And definitely I would agree with more palliative care that has to be funded and promoted. Yeah, to help people like me more.
Kathleen, thank you. Thank you very much indeed for your time this evening, and the same to all our expert witnesses. Very, very grateful to Carol and Kathleen and to Laura and to everyone who's been able to join us tonight. Very quickly to say, this is the first of our meetings. We're going to have a whole series of them. Matt Hancock's going to join us. Robert Buckland, the Lord Chancellor, seeing as this is a question of the criminal law, will also be joining us soon. We're going to have further sessions looking at questions around disability and obviously ongoing exploration of the options for a proper palliative care system in this country. One last thing to mention before I let everybody go, except the handful of parliamentarians who I want to stay and do our extraordinary general meeting with, is that the APPG has a fundraising page which we're using to try and raise some money to do some public opinion surveys and some research. And if you go to Democracy 3, written out, the word 3, Democracy 3, all one word, .org, you'll see a link to fund the APPG for Dying Well on there. So that's or you can find it through our webpage, dyingwellappg.co.uk. So it would be tremendous if we get a little bit of money in the kitty to try and counter the vast amounts of money being spent on the other side. Very grateful once again for everybody's time. We'll let everybody go who doesn't want to watch us go through some formalities now, but I would really appreciate it if we could have at least 5 parliamentarians stay on. I think you know who you are because you agreed to stay at the beginning. So if you're still with us, please stay, and we're going to elect a few more officers to the APPG. But my thanks once again to everybody, particularly Kathleen, and to everyone who's involved and all the people who've come to watch us, and very much appreciate all the time given by parliamentarians and the public. Thank you all.